I want to let Melanie Rumble, the amazing patient outreach coordinator for Cure MLD, do a brief kind of introduction in terms of how this is going to work. And then I'll do an introduction. Then I'm going to introduce our panelists who will be speaking for the entire time. And they've asked that you put your questions in the chat, and then they will address them after they get through their presentation, if that's all right with folks.
Yeah, I think that will probably work best. So yeah, just to go over some Zoom etiquette real quick, because this is a Zoom session rather than a Zoom webinar. I think we're all pretty familiar with the rules of Zoom at this point, but just as a quick reminder, stay muted, and you're welcome to keep your videos on or off. That's up to you. As Maria said, put questions in the chat, and we'll get to your questions at the end. We're going to have Dr. Anik Hogan and Dr. Sunal Patel present, and then at the end we'll have some time for Q&A. And I think that pretty much covers it.
Thank you so much. Okay, so welcome to our first partnership with Cure MLD and the ULF. We're so excited. This is kind of a reunion to be working with the ULF again. And I want to thank Keely Hagg and Melanie Rumble and Bob Browner and new executive director Chris Rice, who have been working tirelessly for probably just under a year to get this event together. I got an email this morning from Keely saying that we had about 45 people registered, industry, doctors, scientists, and of course patient families from all over the world, New Zealand, Alaska, Australia, Brazil. It was truly, just awesome. And so I think throughout the day, people will be popping in and popping out. We'd love to see, while we do ask you guys to mute, we would love to see your families and you. So we'd love to see your faces, and we'd love to meet your children if they're there with you as well. It is my great honor to welcome our panelists today and do this introduction. These are two of my favorite people on the planet. And everyone's been teasing me because this panel is called The Joy of Poop. Now that was actually a joke. And yet somehow that joke title stayed. As a lot of us know in the MLD world, this is a disease that has, presents really great challenges for GI issues, nutrition issues. It is actually it can be a very serious life-threatening condition for MLD children, how to feed them. And we were hearing here at Cure MLD, which we launched in 2019 in our work with families, we heard all the time about the struggles of nutrition, the struggles of eating, and what is the best diet. So it seemed to us that these two remarkable physicians were the people to have to discuss this topic. So let me introduce Anik Hogan. So I'm going to have Anik go first. We're going to go in alphabetical order, and then we'll have Dr. Patel. Dr. Anik Hogan is a complex care general pediatrician at the Children's Hospital of Philadelphia. She's a member of the Division of General Pediatrics at CHOP and an assistant professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She spent her career at CHOP dedicated to the care of medically complex patients, both in the inpatient and the ambulatory setting. Since 2011, she has been the medical director of the Inpatient Complex Care Service. She is the founder and medical director of the CHOP Compass Care program, which provides complex care consultation and care management for medically complex and fragile children across the spectrum from inpatient to outpatient. In 2016, she participated in the development of the Lucas Reese Center of Excellence at the Children's Hospital of Philadelphia. In 2018, she was appointed the medical director of care management and overseeing the enterprise-wide approach of care management for children with medical complexity at CHOP. I will say Anik Hogan is my daughter's doctor, and when people ask me how Cal has lived to the age of 11, which puts her in the top 5 percentile of outcomes for LI-MLD, one of the people I give credit to is the amazing Dr. Anik Hogan. So I'm very pleased to introduce her to the patient community and the KOLs and others who have joined us today. You have it. It's all yours, Anik.
Excellent. Thanks so much. All right, I'm going to share my screen. Thank you for that lovely introduction, Maria. It's really a pleasure to be here with you today. So if you'll give me a moment, I'll share my screen. And Maria, if you can just let me know if that is visible.
Yes.
Brilliant. Thank you so much. All right. So as Maria mentioned, we are going to talk today not just about the joy of poop, but really about really focusing on the entirety of the GI tract. And it's such a pleasure to work with my colleague, Dr. Patel, on this topic. So we're going to take you through sort of from top to bottom. So going through tube feeding, as well as the spectrum of GI issues that you will see within the leukodystrophy population. And we are here representing Philadelphia, CHOP, Paramount School of Medicine at the University of Penn, as well as Children's Healthcare of Atlanta and Emory. So our objectives today. So we're going to go through various feeding tube options for children with leukodystrophy. We're going to talk about how to troubleshoot some of these tube feeding issues, discuss feeding difficulty and various feeding regimens, summarize the nutrition options and dietary supplements, and then the importance of bowel regimens. And like that needs to be underlined, underscored, big bold, the importance of bowel regimens. All right, so from a disclosure, neither of us have anything to disclose, but other than where we are, where we practice. And then just to be clear that this presentation is not intended to provide direct medical advice, but really just to provide some general overviews. Okay, so just to put things in perspective, when we think about feeding tolerance, there's so many factors that go into that. So there is what you're actually feeding. So whether it's formula, whether it's a food product, a blended food product, so what you are actually going to be feeding the body. There's the feeding method, so how you are feeding this. This includes how you're actually delivering the food and then the means by which you are doing that. So whether you are feeding by mouth, whether you're feeding through various types of feeding tubes, and then the ways in which you are giving that, whether it is by way of bolus, using a pump, using a syringe, whatever that may be, so the feeding method. There's the intrinsic motility of the gut, and we all know that can absolutely be affected pretty substantially in children who have leukodystrophies. And then there's your stooling patterns. And we, I think many of us who live and work in this world are well aware that at the end of the day, we do have a relatively, it's quite complex in its own way, but it is still a plumbing system. And so if you want to put things in, you've got to make sure you are emptying things out. Otherwise, there truly is no place to go. Okay, so when we think about the feeding intolerance, I want to make sure that we have that spectrum in mind because they do all work together to achieve that goal. And so if you can have improved nutrition, and really we want to think about sort of optimizing nutrition, knowing that the caloric demands of children with leukodystrophy may not be the same as the caloric demands of children with other conditions. We want to think about weight gain and growth and how to accomplish that, making sure we can meet the energy needs, we can have appropriate bone mineral density, and working together with those things ultimately achieve our goal of having a happier child. Okay, so I want to start out with, how do you know when is this time to think about a feeding tube? And basically it really comes down to, and I'm focusing here today on this population of children with leukodystrophy, not my population of children at large, because there's different considerations in different populations. But when you're no longer able to meet nutritional or hydration goals with oral feeding, or when you're facing a risk of aspiration. So there's many different ways that you can mitigate risk of aspiration even when feeding by mouth. But this has been pretty well studied that in children who are in these risk categories, once the decision is made to get a feeding tube, their quality of life actually can really substantially improve when you're not spending sort of 8 to 12 hours a day trying to figure out how to feed by mouth. So let's go through sort of some of our different types of feeding tubes. So I put these together here, sort of our nasal options, if you will. So starting out with the NG tube, This is your nasogastric tube. Benefits, you can learn how to place this at home. You can replace this at home. One of the downsides is that children really do seem to focus their fine motor skills on how to hook their finger right up next to their nose and pull that tube out. So sometimes you can get a fair amount of practice in replacing this tube at home, but it is a temporizing option. You can feed both bolus or continuous because the tube is going in the nose and right down to the stomach. Considerations we use when we're thinking about when an NG tube is appropriate, we think about how old the child is and how long we think we will need the feeding tube. So this is a good option if that trajectory is not yet clear. If we think that we're looking at how to get through a matter of weeks to months, this is a pretty good option. Now, sometimes we use an ND or an NJ tube, and so that is a nasoduodenal or nasojejunal tube. These are most commonly going to be used in the hospital. And the reason for that is that every time you place this tube, you have to check its placement with X-ray to make sure that it's actually gotten past the stomach into the small intestine, either duodenum or jejunum, as the name would say. And this is something that we would use as a temporary measure in someone who has severe reflux or they are severely having gastric feeding intolerance, so they're not tolerating feeds into their stomach. Like I said, it's a pretty good temporizing measure, and we sometimes use this as a diagnostic tool to help us to know if we were to feed past the stomach, do other symptoms get better, such as respiratory symptoms and things like that. It is pretty rare to use this in the outpatient setting only because every time that tube comes out, you do have to come back to the emergency room to get it replaced and to get an X-ray to confirm its placement. Sometimes we will have that, where my little picture here is use of something called a bridle, which attaches to the NJ tube to help to hold it in place, and that hooks around the nasal septum there. That just makes it more uncomfortable if the child were to yank on it. But again, this is pretty rare to use outside of the hospital. So let's get into our types of tubes. So we've got our gastric tube or G tube, and this can be done with or without a fundoplication. And this is placed across the abdominal wall directly into the stomach. And then you have your jejunal tube placed across the abdominal wall directly into the jejunum. And this can be a standard tube or a button. And then your GJ tube. So this is a gastrojejunostomy tube, and this is placed across the abdominal wall into the stomach. And then on the inside, as you can see in my little picture there, the tube continues and it has that long spaghetti string piece that exits out of the stomach to be able to feed into the jejunum. Now, the advantage of the GJ tube is that you actually have two lumens or tubes on the inside. And so one that stops at the stomach, so you can put, say, medications into the stomach, because some medications get absorbed before the jejunum, but you can put feeds into the jejunum, so past the stomach. And we'll talk more about this in a minute. So I want to walk you through the anatomy of your G tube, okay? So it's important for you to know, and that way you can speak the same language as your healthcare providers, okay? So every G tube is going to have this external anchoring portion, and that is what's going to be on the outside of the body. You have the shaft of the G tube that is going to cross the abdominal wall, and on the inside, you're going to have either a bumper or a balloon, okay? And that's what's holding it in place inside the body. Now, with a button feeding tube, which is what I have pictured here at the lower right, your shaft has a fixed length, meaning that length does not change, it just comes in different sizes, okay? So we think about the size of your feeding tube, you have a diameter size, which we use a measurement called French. So you can have 12 French, 14 French, 16 French. We typically don't go beyond 16 in pediatrics. And then you can have your stoma length. And like I said, in the buttons, those are fixed. So they come in set increments, 0.8 centimeters, 1 centimeter, 1.2, 1.5, 1.7, and so on and so forth, okay? You do have G tubes that are not buttons, what I have pictured here at the lower left. And there you can see you've got this little disc on the outside. That slides along the tube. And so in a standard gastrostomy tube, not a button, the shaft length is adjustable, okay? So you don't have to change the tube itself to have a different shaft length, okay? So now we kind of all know what the parts of the feeding tube are that we're talking about, so we can kind of go forward together with a shared language. Okay, so one of the questions I get a lot is, how do I get a button? All right, I don't want this big long feeding tube, I want the button. And there's advantages to the button feeding tube, okay? So the G button, it's not just that it's inconspicuous. There's value in that because particularly young children have very curious hands and they like to grab things. And what better to grab than this little tubey that's sticking out of your belly? And so when you have a button, when it's not in use, you can close the little cap and clip a onesie over it. And yes, onesies come in much larger sizes, as many of us know. And you have those onesie extenders, thank you, Amazon, that you can get that can allow you to wear them for much longer. But there's a pretty significant advantage to being able to get to a button. So how do you get there? So one, you can start out with a PEG tube, and that is a percutaneous endoscopic gastrostomy tube. These can be placed in interventional radiology by a surgeon or in the by a gastroenterologist in their GI suite. It just depends upon your institution. At my institution, these are all placed in interventional radiology now. But you start out with a PEG tube. That is going to be a longer gastrostomy. That's not going to be a button. But after your first tube replacement, once you have what we call an established tract, meaning that that tract has healed down and scarred down, so we know we've got one clear path that's going from outside the belly directly into the stomach. After you've had that first tube replacement, then you can get a button. Now, you can also get your G tube placed by a general surgeon. In that case, your button may actually be your first tube. Not all surgeons will place a button as their primary G tube, but many of them will. And even if they don't, then after your first tube change, you can get a button there. But many, if not most of the surgeons at my institution will place a primary G tube button. One of the differences between having a surgically placed G tube and a PEG tube is that when you do a surgically placed G tube, they actually do suture the stomach to the abdominal wall. So that tract is going to heal a little bit faster. But either way, you are going to end up with a path that goes directly from the outside world directly into the stomach and scarring down nicely that way. So what about GJ tubes? So as I mentioned, the GJ tube is on the outside. It's actually going to have two separate ports, one for getting into the stomach, the G, one for getting into the small intestine or jejunum, the J. And they stay separate. Those two tubes on the inside are separate from one another. They are not connected inside. They are not in communication. So what you put into the G portion there does not go down to the J portion, and they don't mix with each other. And once you get across the abdominal wall, you've got that long spaghetti piece on the inside. So your sizing here is going to be, again, your French size, how wide that tube is. You're going to have your stoma length, and these come both in the ones you can see with the disc here at the left that slides along, so you have an adjustable length. These do have a button, so there's one button here right in the center, another button here that is off to the left. This is the AMT brand and the Mickey brand, and that just depends upon the brand that your organization uses. And they have those will have a fixed shaft length, but then these also come in different sizes based upon how long that spaghetti piece of the jejunal portion is, so we can tell how deeply that's going to go within the jejunum. Okay. Now there are some downsides of the GJ tube. One, every time you have this placed, it has to be confirmed fluoroscopically, so with an X-ray, to make sure you've actually gotten into the jejunum. This has to be placed in interventional radiology. So you cannot replace this tube at home. Also, by virtue of having this very long spaghetti piece, you've got a long piece of plastic, so that's going to clog. It's almost inevitable that you're going to have some clogging issues. And you can have clogging of either lumen, the G or the J lumen, because these are just longer tubes, okay? Another problem is that the jejunal part, this long spaghetti part that's exiting out the stomach, up until very recently, the smallest one that we had that was a button GJ was 14 French. So 14 French again tells you your diameter. Well, that was just too big and too fat, basically, for many of our smaller children. And so very recently, AMT has come out with something called the micro G-Jet, which I have pictured for you in the middle at the bottom. And so this one here, what it's worth noticing is the jejunal piece, so this long spaghetti piece on the inside, is only 8 French. Okay, that's important. I personally have been waiting a very long time for this tube to come out, to have an option here, because this gives us a button GJ option for children that are less than 10 kilograms of weight. Because if you have that tube that's just too fat, one, you can block the outlet of the stomach, and that can lead to pretty significant problems. And two, you can have a risk of something we call intussusception, where the small intestine actually sort of telescopes in on itself. So once you have your feeding tube, they are not without their issues. Like I said, these have been shown to improve quality of life in terms of being able to have a safe way to feed your child, but nothing is without its problems. So let's talk through some of those issues. So one of the common issues you can have is tube dislodgement. So with your G tubes in particular, let's start with those. So here it's really, really important to know whether you've had the tube changed for the first time or not. We refer to this as a fresh tract or an established tract. So if the tube has never been changed before, so this will tell you you're within the first couple of months of having your tube. If it's never been changed before and that tube comes out, that tube cannot be used until its placement is confirmed again, to ensure that we're actually getting back into the stomach and not somewhere else in the abdomen, such as in the area we call the peritoneum. So if the tube comes out before that first tube replacement, we ask all of our families to come directly to the emergency room. If you still have the tube, you can deflate the balloon and just try to insert it back in there to keep the tract from trying to close up. But we do ask families to come right away to the emergency room. That way we can replace the tube. We do a little dye study. We ensure that the tube has now gotten only into the stomach and not anywhere else in the abdomen, and then the tube can be used again. Now, if the tube is dislodged, but it's an established tract, meaning that you've already had the first tube change, we know that that tract has healed nicely so that we know that the tube is only going into the stomach, then the tube can be replaced at home. And everyone, when you have a G-tube, should always have a backup G-tube kit at home, so that if that tube were to be dislodged, and let's say the balloon broke, you will always have another tube available to be able to put in there. Now, if you've already used your backup and you don't have another one available and the balloon broke, you can still put the G-tube back into the tract, just without the balloon inflated. Put it back in there, put a piece of tape over it to hold it in place, and that way you won't have the tract start to close until you can call your home care company. Sometimes they can do a same-day delivery, or if you need to, you can present to care to get another G-tube. But tube dislodgement is still quite an issue. Like I said, with the GJ tube, unfortunately, if your tube dislodges, there's no option other than to come back to intervention radiology and have them replace it. Now, leakage. So leakage can be quite an issue. Now, I like to separate out thinking about leakage into big categories. So one, there's the tube problems. Two, there's the skin problems. And three, there's sort of the pathophysiologic problems. And I'll get to those, and that's a bigger category. So let's start with the tube problems. So first, it's important to think about making sure you've got the proper volume in your G-tube balloon. So on the tube on the outside, it will actually have, particularly for the AMT brand, it will actually have a volume written on there. That's not the maximum volume it will hold, but that's sort of the recommended volume. But one of the things that I often ask people to do is just check to make sure you've got the proper volume in the balloon, because if that balloon volume is too small, then you're not going to have a good fit of the balloon up against the stomach wall on the inside, and things are just going to leak right around it. Okay. Another issue is that you may not have a proper fit of the G-tube. So if that shaft length is too long, then you're going to have what I refer to as pistoning of the tube. I'm going to show you a picture of this so you can see. So this is a little pictogram of a G-tube, and you can see the balloon on the inside and this sort of pink stomach wall, and that weird orange color is meant to be the abdominal wall, and you've got your external anchoring portion, the shaft there. This is a good fit. You want it to sit and rest nicely on the stomach wall. You don't want it to be sticking out, because if it is sticking out away from there, and you've got the external point that's sticking out a little bit too long, what you can have happen is this. And so you see that movement of the tube there. So one, that moves the balloon away from the stomach wall on the inside. Contents can just leak right around it. Two, you've got friction there. So you're going to create granulation tissue, which is just chronic inflammatory tissue. And so that friction will create more granulation tissue, and the leakage will also create more granulation tissue, and that will just lead to more problems. So your second category of issues is the skin issues that lead to leakage, and one of them is granulation tissue, which can ooze its own fluid and also as a consequence of leakage. So I want to draw your attention to, in the interest of time and not going in super duper detail through these things, on the internet, on the CHOP out-facing page, chop.edu, we have these clinical pathways. And recently, several of my colleagues put together a really nice pathway on complications with G-tubes. And you can click on, these are open to the public, anyone can reach these. And you can click on any of these links. These are hyperlinks. I put the website on here for you. And you can click on any of these, and they will take you through, and they will show you different pictures and different guidance as to how to respond to these. So the third category that can lead to leakage is significant pathophysiologic issues. So anything that creates a lot of pressure, where the path of least resistance is to get out through the tube. And that's where Dr. Patel's part is going to come in, really looking to make sure that we can ease the downstream pressure. The other piece that's really going to help here is venting, which I'm going to get to in a minute. So skin issues, this is what I was starting to talk about with the granulation tissue, with irritation of the skin, with infections at the skin as well. I will ask you to refer back to the pathway that I showed you, because it really does walk you through those issues really quite nicely. The big takeaway that I would like you to bear in mind is that one of the things that the skin wants most at that G-tube site is to be clean, dry, and protected. Okay? Clean, dry, protected. So that just means using nice, gentle soap and water to clean around there several times a day, drying around there, doing a nice little air dry. And then once you've got nice and air dried, protect it. So what do you use to protect it? Anything with zinc oxide, okay? So that can be Desitin, that can be Calmoseptine, that can be a generic of any of these things. Anything that's gonna have zinc oxide is gonna protect the skin to allow it to heal itself and shield it from moisture. Clean, dry, protected. One of the next issues that I see commonly, particularly in leukodystrophy patients, but also really in any of my patients where they can have a lot of pressure on the abdomen, is balloon breaking. So this just really comes down to, there's just a tremendous amount of pressure that gets put on that balloon on the inside. And so some people do need to change the balloon more often than every 3 months that the home care companies will, and the insurance will typically provide the tube. And that's fine. So some of my families will replace the tube once a month instead of every 3 months. But once you find that you are getting breakage that's happening If it's starting to happen once a week, once every 2 weeks, you might want to think about another tube option. And I just want to draw your attention to the fact that there are button G tubes that don't have a balloon on the inside, but have this little bumper device. And we just use this little a trochanter to extend out that bumper. But basically it has a different mechanism of holding it in place, a bumper and not a balloon. So then that's not gonna break. So you get the right fit on your button G tube, and you don't have to worry about the balloon breaking. This does need to be replaced in the office. Rather than at home. It is harder to replace at home, but it's coming into the office a couple times a year. And then finally, clogging. So clogging, as I mentioned, is more of an issue with the GJ tubes. And really what it comes down to is we know the things that clog the tube. We know it's the medications that don't dissolve particularly well. We know that it's the fatty components of the foods that we're putting in there that lead to clogging. And we know that GJs clog more because they're longer. So the key here is frequent flushing. And remembering that going back to your physics, that a small volume syringe gives you much better pressure. So you can do frequent flushing just to keep that tube nice and cleaned out on the inside, so you don't get little fatty particulates that will adhere to the sides. But then if you do start to get sluggishness, use a small volume syringe, like a 3 ml syringe, not that 10 or 20 ml syringe, because you'll get more force with, we start with warm water, but if you've heard other people say that they use some sort of a soda, like, you know, a cola or ginger ale, doesn't really matter. That is true. The carbonic acid does help to break up those fatty clogs. And the other thing that we use in the hospital is something called Clog Zapper, which just has enzymes in it that are going to help to break up that fat. And then finally, I want to take you through venting. And so when we think about venting, we have 2 main ways to accomplish venting. So the one is the Ferrell bag. And so the Ferrell bag you can see pictured here, and it's just a plastic bag that has very long tubing. And if the bag is above the level of the person, then you can have air that can come out through the tubing. It just connects onto your G tube and goes up into the balloon that has a little valve on the inside there. The thing I will tell you about the Ferrell bag is you need a lot, you need to have a lot of force to overcome the resistance of the Ferrell bag. So it's not necessarily the most effective way of venting, okay? Because long, skinny tubing has very high resistance, okay? One of the more effective ways of venting is doing the chimney. And that basically is just taking your 60 ml syringe, you take the plunger out of it, and you just connect it to, this baby happens to have a Malacot, my little doll here, but any extension tube. I recommend typically using your straight extension, not the right angle one. Again, you don't make air have to go around a corner. And allowing those gas bubbles to come out, and a gentle massage on the belly so that bubble can find its way through the tube can really, really help to get those gas bubbles out. That's gonna help to reduce leakage. And that's going to help to reduce balloon breakage, and it's going to really increase comfort. And with that, I would like to hand this over to Dr. Patel. So I'm going to stop sharing.
Can I quickly introduce Sunil very quickly, guys? Because I think it's important.
Sure.
Yeah, please. So Sunil Patel is a pediatric gastroenterologist at Children's Healthcare of Atlanta in Atlanta, Georgia. Her 5-year-old daughter, Radha, was diagnosed with late infantile metachromatic leukodystrophy at age 2. Her professional interests include enteral nutrition, general gastroenterology, and patient advocacy. Her experience raising a child with special needs has inspired her to advocate for medically complex children and their families. So Sunil is a doctor and an MLD mom, and just an incredible gift to our community. I'm so excited she's speaking today.
Thank you so much for the introduction, Maria. Okay, let me share my screen. Desktop. Share.
Your screen's as messy as mine, Sonal.
I know. It's an organized mess, believe it or not.
I believe it.
I can find everything on there without an issue. Excuse me. Okay. So thank you, Dr. Hogan, so much for a great presentation. And just picking up from where she left, So once you've identified that your child requires enteral nutrition and a method for feeding has been established, it's now time to think about what types of nutrition you want to give your child. Really, the medical and dietitian team can help guide you to pick a formula that's best, but do know that there are just dozens of commercial formulas, there are prepared blends and purees that are available for tube feeding. The goal is to determine which form of nutrition best fits your child's needs and tolerance level and can realistically be prepared and administered by caregivers. So when thinking about some feeding options, probably the most commonly used forms of nutrition are standard or what we call polymeric formulas, as well as semi-elemental and elemental commercial formulas. And then moving on to a blended option, these can be either commercially prepared or you can make your own at home. There's also something called a puree by G-Tube diet, which we'll talk about in a little bit. And then I think it's important to realize that it is possible to use a combination of these feeding options. Just because you use one doesn't mean that you can't use others. And it is absolutely possible to use a few different ways of nutrition to feed your child. So when talking about standard formulas, I do want to mention that the nutritional options we're going to discuss today are meant for the toddler and older age groups. We're not going to be discussing infant formulas today, but within these brands, there are multiple subtypes, some of which have higher calories, some of which have fewer calories, some have fiber, some do not have fiber. So within each brand, there are various iterations. But the first two polymeric formulas I wanted to talk about are Pediasure and Boost Kid Essentials. These are probably the most commonly used formulas that patients that are started out on enteral nutrition receive. One of the concerns that comes up frequently, though, is the sugar content. And it is true, they do have quite a bit of sugar, which is why other formulas are available, and you know, we'll go through some of these other ones. So Nutrin Junior is another standard formula. It's made with 50% whey protein as well as some soy protein. Complete Pediatric is made with real food ingredients, but do know that it's not made with whole food, and it does not contain soy or corn product. And then Kate Farms is a newer formula that's been on the market. It is organic. It's made with pea protein, so it's vegan, and it contains no soy, nuts, or corn. And the caloric content per milliliter is also slightly greater than some of these other standard formulas at 1.2 calories compared to the 1 calorie per milliliter in some of the other standard formulas. Moving on to semi-elemental formulas, these products contain protein that is extensively hydrolyzed. So it's a little bit more broken down compared to some of the standard formulas, and presumably a little bit easier to digest. Peptamen Junior is made with whey milk protein, and it also contains other milk products as well as soy ingredients. Pediasure peptide is made with whey and casein milk protein. And then again, pediatric peptide made from Kate Farms is organic, vegan, and contains no soy, nuts, or corn. And then there are also concentrated versions of these formulas. So all of these you'll see have 1 calorie per ml, but they also come in a 1.5 calorie per ml. So you get a little bit more bang for your buck if your child is volume intolerant. And finally, moving on to the elemental formulas, these have protein molecules which are broken down to the amino acid level, so extremely, extremely digested, and presumably are the most easy to tolerate or best tolerated. Elecare Junior contains no milk, soy, and then from a sugar standpoint, it's also fructose and galactose free. Alphamino contains no milk ingredients, and Neocate contains no milk or soy oils. So moving on to commercial blenderized enteral nutrition, this is made from whole food that's been blended down into a very thin consistency. It's been commercially packaged and is sold. Complete Pediatric Organic Blends is organic, as the name says, and it contains no dairy, soy, or corn. There are 2 varieties, one of which is plant-based, and then the other is made with chicken. Nourish is vegan. It's also organic and contains no dairy, soy, corn, or nuts. And then there's also a nourish peptide that's been recently released. So similar to the standard formulas that had the semi-elemental proteins that were extensively hydrolyzed, they have a peptide version of this blenderized formula. Pedisure Harvest is a product from Abbott that contains no dairy products. And then finally, Real Food Blends is a supplement. So it's not nutritionally complete, but it can be mixed with other formulas or food products to meet nutritional requirements. And there are 6 formulations of this that contain various foods. But just know that with the Real Food Blends, it is not nutritionally complete, so cannot be used as a meal substitute. So say you've been through the nutritional buffet, the enteral feeding buffet, and you've kind of tried all of these different formulas and nothing really seems to be working. You've done the commercial blenderized diet and you want to just try something new. There is the option of creating your own home blend. Again, with initiation of any change in nutrition, particularly with the blenderized diet, it's important to consult with your medical team. But what are some of the pros of doing a home blend? One is that the nutritional source consists of whole food. So you're taking sweet potatoes and green beans and chicken broth, and you're cooking it at home and blending it down to a thin consistency and giving it to your child. You have control over the food that you're giving your son or daughter, and it's made with your own hands. You have an opportunity to introduce a potentially wider variety of foods, and there have been reports of improved intolerance, although this is anecdotal, and it certainly varies by child. Now, what are some of the cons? It is time consuming. So you need to many times cook the food ahead of time to get it to a consistency that will be blendable. It requires a commercial grade blender, which can be expensive. So your osterizer isn't going to do it. You need to buy a really powerful blender. And, all of the materials that you're going to need are not covered by insurance, and you're going to have to pay for all of the food and supplies out of your own pocket. You'll need a freezer for storage, as well as glass jars if you're planning on making it in batches and storing it and then freezing it. There's always a risk for contamination during food preparation, of course. And then always there's this trouble with excessively thick blends, and how do you get that through a pump? And there can be some difficulty with administration if you don't have your recipe kind of fine-tuned. So these are examples of some of the commercial grade blenders. This is a Vitamix on the left, and this is a Blendtec on the right. Now, Blendtec does have a reimbursement program on their website. And if you go onto their site, there's some forms that you can print off and have your medical provider fill out. And then you would have to fill out some information as well. And then once you send it in, they will discount or reimburse you for a portion of your Blendtec blender. Now, as mentioned previously, there's this Puree by G-Tube diet, and this is enteral nutrition that consists of pureed baby foods. It's mixed with either formula or milk. It was initially intended for children who had excessive gagging and retching. That is unfortunately a side effect of a fundoplication, which is where the top of the stomach is wrapped around the bottom of the esophagus for patients that have severe vomiting and reflux. But it can also be very useful for children that have feeding volume intolerance. It involves giving 2 to 4 ounce bolus feeds every 2 to 3 hours of pureed foods. But because the consistency of the food is thicker, it requires a larger G-tube size. So you need to have at least a 14 French, ideally a 16 French G-tube. And then administration is with a plunger syringe, using the larger syringe sizes. But you always need to make sure that you talk with your dietitian to make sure that your child's gaining weight and that they're getting enough fluids, because that's one of the challenges. You're giving them a lot of puree, but how much liquid are you actually giving them? So sometimes it becomes necessary to add calorie supplements to a child's nutrition to help boost the amount of calories they're receiving without actually increasing the volume. So vegetable oil and olive oil, as well as heavy whipping cream, are inexpensive household items that can be easily mixed with formulas or with blends. There is medium chain triglyceride oil, which can be found at health stores. It can also be found online. MCT oil is directly absorbed by the intestinal tract and may be better tolerated than some of these standard oils or creams. And then Benecalorie is a fat and protein additive, and it adds actually 330 calories in just 44 milliliters of liquid. Duocal powder is a carbohydrate and fat additive in a powder form, and it provides 55 calories in 2 scoops. And then finally, microlipid is 50% fat emulsion that contains safflower oil, and it provides 67.5 calories in 15 milliliters of liquid. So once you decide on the type of nutrition you would like to give your child, you have to next decide on how you want to administer the food. So giving feeds by bolus administration means that you're providing interval feeds throughout the day that typically occur in over an hour or less, ideally. And this can be achieved in one of 3 ways. There's a gravity bolus, which is direct administration of nutrition with a large syringe without the plunger through an extension tube. So it's kind of like the reverse of venting. You're basically filling up the chimney with formula and letting it go in. And then there's a pump bolus where a feeding volume is administered via a pump at a specific rate. And this is really good for formula or blenderized diets. They are able to be administered by pump. And then syringe bolus, which is where the feeding volume is administered directly with the syringe, excuse me, with the plunger. And this is really good for the period by G-tube diets, but can also be used with formula and home blends as well. And then talking about continuous feeds, these can be either truly continuous, meaning that you're getting feeds for 24 hours a day without a break, or continuous with breaks, which means that the pump runs for a certain number of hours in a day, and then there are breaks intermittently, and there's time left off of the pump. So next, I'd like to switch gears a little bit and talk about the role that gut motility plays in feeding tolerance. Excuse me. Patients with leukodystrophy often develop decreased or absent gut motility due to the underlying neurologic injury that they endure. The enteric nervous system innervates the intestinal tract and is likely affected by the neurologic disease. When this occurs, patients can develop vomiting, constipation, pain, gas and bloating, and reflux, all of which can lead to poor weight gain. Additionally, GI motility is further affected by limited generalized movement and minimal upright positioning. So in situations where we know that there are issues with gut motility, there is a role that medications can play in terms of improving symptoms. So erythromycin, bethanechol, and Reglan, also known as metoclopramide, all improve stomach emptying. Erythromycin can lose efficacy over time, and metoclopramide should only be used for a limited number of a limited number of months to decrease development of certain muscle and movement disorders. And then cyproheptadine is an antihistamine medication that can improve stomach expansion during feeding. Side effects include drowsiness, so this is why we typically give it at night. And then finally, simethicone and dimethicone can help improve bowel discomfort from gas. And finally, as it's time to address the stooling habits, which is the namesake for our talk today. Causes of chronic constipation in the leukodystrophy population include poor gut motility, as we previously described, suboptimal hydration. I think this is underappreciated, actually. We oftentimes limit the amount of liquid and free water that we give our kids just because we don't think that they'll tolerate it and we don't want them to vomit. But this can severely cause constipation. Also, there is an increase in insensible losses, whether it's through increased salivation, poor control of oral secretions, instability of body temperature, and you're sweating a lot and losing water in that way. neuroscoliosis. So when the curvature of the spine worsens, that can affect motility of the intestinal tract as well. And then, like I said before, with decreased activity, this just generally leads to decreased peristalsis, which is movement of food content through the intestinal tract. And this includes also limited weight bearing. So when thinking about how best to get a child to stool, we have to think about the mush and the push. And this is the term that Dr. Hogan actually taught me, and I've really embraced. So the mush is essentially an osmotic laxative. It's the medicine that helps bring water into the colon to soften the stools. And there are many options for getting stools to mush. One is polyethylene glycol. This is Miralax. Magnesium hydroxide is another. This is milk of magnesia. Docusate or Colase. And then magnesium citrate is, if you've gone to the pharmacy recently and seen those glass bottles with colored liquid, that's what that is. It's used mainly for bowel cleanouts, but can also be used just for, sort of standard daily administration in smaller volumes. And then the push, this is stimulant laxative. So this is the part that's going to help the colon actually squeeze out the stool and evacuate. Stimulant laxatives include Senna, which come in liquid and chocolate forms. This is X-Lax, and then Bisacodyl, which is Dulcolax, and they come in various forms. Sometimes they're a tablet that you can crush. There's a suppository, so there are various forms of Bisacodyl. So say you're going about, doing your mush and push bowel regimen and you're still not seeing results. What do you do when more is needed? I think probably one of the first line interventions is to administer a glycerin suppository. This causes relaxation of the anal sphincters, allowing for evacuation of the rectum. Bisacodyl suppositories, as I mentioned, are provide rectal stimulation. And then a saline enema can be used to really kind of irrigate the last portion of the colon and flush out all of the stool that might be impacted. I do want to make mention that water should never be used for administration because this can cause quite severe electrolyte abnormalities, which can be dangerous. And then in very, very bad situations where you just need sort of a reset, a complete bowel clean out may be warranted. And this is not a bad thing. Some kids feel absolutely phenomenal after completing a bowel clean out. And it's messy, but if you're going to have a happier child at the end of your day, it's well worth it. And this is done by mixing a larger amount of polyethylene glycol with an electrolyte solution, usually Pedialyte. And you can also use Senna to get that stimulant effect if needed. And again, magnesium citrate can be used, but just monitor carefully for signs of dehydration. Patients with leukodystrophy are quite labile and can respond very severely when becoming dehydrated. So that would be the one thing to look out for if you're planning to do a complete bowel clean out. Our goal is to pass a soft formed bowel movement every 1 to 2 days. So I usually let my patients know that if you're not going according to this, then something else needs to be done. Something else needs to be changed. So I hope this information was helpful to help everyone understand some of the factors which can contribute to feeding intolerance in the leukodystrophy population. And do keep in mind that when feeding is tough or not going as smoothly as you think it should be, there are many different approaches which can be taken to try to address issues and make improvements. Thank you so much for your time, and we're happy to open up for questions.
We only have time for a few questions, I'm afraid, because we're running on a pretty tight schedule. So please go ahead and raise your hand and ask your questions. 2 messages. Let me see here. Let me see. Okay. What? Okay. This is from Adamir in Brazil. I am so sorry because I'm entering this a bit delayed. I'm not sure if somebody spoke about this. At Mickey, to inflate the balloon? What kind of liquid can we use? Here in Brazil, they normally use saline solution, but I think may not be the best option. So anyone want to answer Adamir's question from Brazil?
We just use water.
Water's fine, Adamir. That's what I was thinking. Yeah.
Yeah.
Just water's good.
Just water.
I hope
it doesn't need to be sterile water because the GI tract is not sterile. So just water. Great. Any other questions? That was an amazing presentation. The great news, guys, is that this presentation will be recorded. So we're going to be putting this on our website. I think this is such an incredible resource, and we'll be, of course, I think providing more opportunities for Dr. Hogan and Dr. Patel to, have these discussions and talk more about blenderized diets. And I'm a big believer in intermittent fasting, which we can talk about another time, about giving your kids a day off from eating and just doing fluids. Happiest day of the week here at our house is when we do intermittent fasting. It's good for kids and adults. I want to thank our amazing panelists, and we're going to move on to the next program if that's okay. So I'm going to be brutal about time because they're shutting us down. Thank